Hello, everyone. Hope you're doing good and doing healthy and close to your family. I'm Dr. Ardashir Ranjbari on behalf of the Every Smart Group. Uh, Wanted to say welcome to this program, and this is the another session of the Dental Talk. Right now, we have a special guest, a good friend of mine, good old friend of mine, Dr. Hamid Fallahi. He's an oral and maxillofacial surgeon. Right now, we going to talk about the subject of third molar surgery or wisdom tooth surgery, and actually before the starting, I'm going to talk about and to going to introduce the Dr. Fallahi, very concise and very concise bio of him. Actually, Hamid is the board certified oral maxillofacial surgeon, and Hamid has completed his study in uh, School of Dentistry, University of Ahvaz Jandi Shahpur in post and also the undergrad. Uh, Completed his study over there. Hamid is one of the first generation of our students that have been graduated from that School of Dentistry. I'm really proud of him because he was very talented, and right now he is a very brilliant the person who's working as an oral maxillofacial surgeon in my back home, Ahvaz, Khuzestan. And also he's in very going to be the international um, doctor and they're just working on his specialty. And of oral maxillofacial surgeons, he published lots of articles, which is very precision. There was very brilliant articles. And right now, I wanted to ask him to talk about and starting his subject, his title. And Hamid, thank you, and let's get started. Thank you very much.
Thank you, Ardashir. I would like to say hello to my colleagues. This is my honor to be with you in this episode of Dental Talk. The topic is third molar surgery. Do similar basics fit for all cases? I will show you that with respect to some basics, you can do surgery for your patients. The goal of my lecture is divided to 4 parts: type of impaction, causes and classification, indication and contraindication of impacted tooth removal, and surgical techniques, and I will discuss about some common complications. There are some systemic causes, like some childhood disease and syndromes, such as Gardner syndrome, cleidocrinial dysplasia, ectodermal dysplasia, Down syndrome, which can cause multiple teeth impaction. Also, there are some local causes, such as blocking of growth paths due to thick superficial soft tissue, thick alveolar bone, or interference with adjacent erupted teeth when the impacted teeth are not at an appropriate inclination, and abnormal tooth morphology. And the most common factor for causing an impaction tooth is dental arch discrepancies. Also, some additional factors such as malformed teeth, a remaining deciduous teeth, and some cysts and tumors can cause impaction. As a general rule, we should know that all impacted teeth should be removed unless the extraction is contraindicated. It means that removal of impacted teeth is necessary, but it is not urgent. So, the dentist must perform surgery when appropriate for the patient. It is not a good option to suggest to our patient that to postpone tooth extraction until the problem arises, because this suggestion could make big problem for patients, such as pathologic process, loss of adjacent teeth, inferior alveolar nerve damage, and sometimes make a big problem like infection in oral and maxillofacial spaces, and make the patient have an emergency status. And so it will make surgery more complicated. This slide gives you some indications for extraction of impacted teeth. Prevention and treatment of precoronitis, prevention of periodontal disease, prevention of adjacent tooth root resorption, decay and toothache, prevention of formation of cysts and tumors, prevention of interference with prostheses, prevention from jaw fracture, and preparation for orthodontic treatment and sometimes for orthodontic surgery. If you look at this slide, you can find the word prevention. The word prevention used lots of times in this slide. It means that the main cause of removing an impacted teeth is prevention. And as we know, prevention is more important than cure. One of the most common questions that patients and even my colleagues always ask us is, when is the optimal time for extraction in impacted teeth? The ideal time for removal of third molar is after the formation of 1/3 of the root. It means it is around 17 to 20 years old. The most common contraindication for extraction of an impacted tooth is older age. The older the patient, the less bone flexibility is. So it makes your surgery more complicated and resulting in less flexion. And so when you use forces against the tooth to remove it, you need more forces. And as a result, more bone must be removed to make tooth extraction possible. The more bone you remove, the more complication will arise. So in patient over the age 35, we always suggest to do not do elective surgery for over 35 years old. An asymptomatic impacted tooth with intact, healthy covering bone do not need to be removed after 35. Of course, we should tell your patient to be in close contact with your office and monitor every 1 or 2 years. 2 years.
Sorry, Hamid, to interrupt you. That I have a question. That as you mentioned, that if we find that the patient has an impacted tooth in the teenage ages, okay, you will recommend that it should be extracted and should be removed, the tooth between the 17 to 20 years. It is the best time to remove that, yeah?
Yes, of course. The best time for remove the tooth is between 17 and 20 years old. Because
that's good.
Bone flexibility is very high. You do not need to remove lots of bone around the tooth. The roots are not completed, and so the risk of inferior alveolar nerve damage is lower. And also, I will show you in next slides, and also in this age, the healing process will be better. And there is there is less complication after your surgery.
Okay, sounds good. Okay, good to go.
Also regarding to contraindications, there are some, if your patient have some uncontrolled underlying diseases like respiratory or cardiovascular dysfunction, immunosuppressed patients, in these cases, it is really important to give sufficient explanation to your patient and tell them that you do not need to do an elective surgery. You should be monitored regularly. And if in case of any problem raises After that, the patient should be referred to an maxillofacial surgeon for removing the tooth. Also, the most common contraindication is possibility of serious damage to adjacent tissue, vital structure, and teeth. Serious damage to adjacent structures such as inferior alveolar nerve damage, tooth damage, like a second molar damage, jaw fractures, and something like that. There are lots of advantages for early extraction of impacted teeth. Some of them are reduced post-operative complications and acceleration of the healing process. It is easier for young people to tolerate a wisdom teeth surgery, and due to the higher rate of healing in younger patients, the period of the daily activity disruption will be shorter in these patients. Also, the restoration of periodontal tissue in the distal region of the second molar is more desirable in young people. On the other hand, in case of inferior alveolar nerve damage, the chances of spontaneous recovery in young people are great higher. Due to the lower bone density and less development of the tooth roots, surgery will be performed more easily. Okay, let's talk about pericoronitis. Pericoronitis is an inflammation of the soft tissue surrounding the crown of a partially erupted tooth. This is important. We are talking about partially erupted tooth, including the gingiva and the dental follicle. The etiology is always, it could be happen by following a mild trauma caused by the maxillary third molar. The maxillary third molar may also worsen a pre-swollen operculum. If we do not pay attention to the pericoronitis and to the inflammation, mild inflammation in this side, patient may encounter severe problem like these photos, and infection in the head and neck spaces maybe arises. And it change your patient from the urgent situation or urgent status to an emergency status. So removing the wisdom teeth, especially a partially erupted wisdom teeth, is necessary to prevent such a problems. The most common bacteria detected is alpha hemolytic streptococcus. Okay, what should we do when we have an pericoronitis? The early treatment phase is mechanical removal of bacteria through the hydrogen peroxide irrigation. Hydrogen peroxide could remove all anaerobic bacteria through the release of oxygen. Other mouth rinses such as chlorhexidine and iodoform could be helpful too to reduce the number of bacteria. Even the high force injection of normal saline could reduce the number of bacteria. So the first stage is rinse the place more and more. And regarding to, since pericoronitis often could occur around the mandibular wisdom teeth, the first stage of surgical intervention is to removing the antagonist maxillary third molar. Sometimes it could be surprising for your patient and ask you, my problem is in my lower jaw, why you want to remove my upper third molar? This is really always happen from your patients, and they ask you. The answer is explain them. Just explain them that the etiology of pericoronitis, that if the maxillary third molar make mild trauma over this inflammation and make worsen your status. So the first stage is removing the opposite maxillary third molar, and after that prescribe some antibiotics and some painkiller for your patient, instruct them to how to rinse the operculum, and after a few days, when the condition is more stable, try to remove the wisdom teeth by surgery. In this slide, we can see another common problem around an impacted teeth. This is a periodontal pocket formation between the impacted teeth and the second molar. If we do not treat this, the condition may worsen, and the forcation involvement will happen. And as you know, cleaning this kind of periodontal pocket is really difficult. Sometimes it is impossible. And so the good option is to remove this wisdom teeth early before this periodontal pocket may worsen. And after removing this, it could accelerate bone regeneration in the sides. Another two problem is tooth decay and root resorption. In 2017, me and my colleagues published an article about investigating the relationship between the type of impaction of mandibular third molars and the caries of distal surface of mandibular second molar. We concluded that the angle of impaction, mesioangular and horizontal, and the class 2 has significant correlation with caries on the distal surface of the second molar. So it is important to remove the impacted teeth to prevent from caries on the surface of the second molar. On the other hand, the presence of impacted teeth can be cause of pain of unknown origin in the jaw and facial region. So in case of no cause is found, it is important. In case of no cause is found, so it means that the first stage is to try to looking for another cause of facial pain. If we cannot find any cause, then we could remove the impacted tooth as a cause of facial or orofacial unknown origin pain. Okay, let's talk about the classification of mandibular wisdom teeth. The most common classification and one of the simplest classification for system for wisdom tooth is the classification based on the angle of the wisdom tooth with its adjacent teeth. Based on this classification system, we have four categories: mesioangular, horizontal, vertical, and distangular. Mesioangular is the most common and hopefully is the most the easiest type for surgery. On the other hand, distangular has the most difficult type surgery, but hopefully again it has it is less common than the other types. So it is a good news for us that the most common type is mesioangular, so we can do surgery for large of our patients. The other classification system is introduced by Gregory and Pell. They divided the teeth into three classes according to the amount of bone covering the surface of the wisdom teeth. Look at the this part. So this is class A, which when the surface of the wisdom teeth is at the level of the occlusal surface of the adjacent tooth, it is class A. When the surface is between the occlusal surface and the CEG of the second molar, it is type class B. And when the surface of occlusal surface of the third molar is under the CEG of the second molar, it is class C. On the other hand, Pell and Gregory classification based on the amount of teeth covered by the ascending ramus, by the anterior border of the ramus, they divided into three classes. Class 1, when the whole part of the impacted teeth is anterior of in front of the anterior border of the ramus, is class 1, and when the tooth is completely behind the anterior border of the ramus, it is class 3, and in this situation is class 2. This is another article that me and my colleagues published regarding the influence of growing status of third molar on mandible angle fracture. This is amazing that we concluded that when the third molar is deeper, there is a lower risk for angle fracture. Growing third molar of class 1A in Pell-Gregory system and also vertical position had the most risk of angle fracture. It is because of the direction of forces and the angle part of the mandible and the weakest and the strongest part of the mandible. And so it is another reason to remove remove the impacted teeth. The gold standard for radiographic evaluation of
Hamid, sorry to interrupt you. We have an interruption in your. I think it's about the internet problem. Would you please back in the going back to the previous slide?
This
And
is
yeah, I had an interruption.
okay. Is the connection good right now?
Previous slide, middle of the previous slide. Okay. But would you please?
Yes. Sorry for interruption. I think my
Talk about the.
Yes, I think my internet connection is a little bit problematic right now today. Sorry for interruption. I was talking about classification.
No, I had it. I had your image in this slide and the other one. But when you were talking about an article.
Okay. I will go on from this slide.
Yeah.
Okay. This is an article that me and my colleagues published about the influence of growing status of third molar on mandibular angle fracture. We concluded that when the third molar is deeper, there is a lower risk for angle fracture. It's amazing. Growing third molar of class 1A in Pell-Gregory and vertical position had the most risk of angle fracture. It means that when you have a growing third molar, the risk of angle fracture is higher. This is because of the direction of forces and the weakest and strongest part of the angle.
That was interesting article, yeah.
The gold standard for radiograph for evaluating the wisdom teeth is panoramic radiograph. Please, I always ask from my students to please do not do wisdom teeth surgery just by a small preapical radiograph. You need to have a panoramic view because it helps you to understand the situation and it helps you to know what is the classification of this impacted tooth, and it helps you to estimate the difficulty score of your surgery and this better decision. And so when you know what are you doing, the complication will be lower. And after a panoramic radiograph, if you see some problems in the panoramic radiograph, such as some cyst or close contact with inferior nerve canal, you need to have CBCT, CBCT from the place. I talked about bone density in previous slides, but I want to again talk about it that patients over the age 35 have more dense bones. So After
Uh,
35,
Hamid,
I do an active stroke.
sorry, Hamid, would you please go to the previous slide? We go to
Yes, of
previous
course.
slide. I have an interruption. Yeah.
Okay. I was talking about this point that if you see some problem in the panoramic view, like close contact to the inferior alveolar nerve or some cyst or another problem, you can order a CBCT for your patients.
So in this time, I have another question that Hamid, is there mandatory to take an CBCT for all of the patient or not? The panoramic is the choice, but if you haven't find any problem or you can diagnose the very detail of them and you need another additional information, you order the CBCT.
Yes,
Yes.
yes, exactly. This
Okay,
is
that's
the
good.
point. We do not need to order CBCT for routine mandibular third molar surgery or an impacted third molar surgery.
Okay.
This is a very good slide that show us the factors that make the operation more difficult. Deep impaction, maybe sometimes if you have this kind of impaction like this slide, let me mark it like this. Maybe it is better to do surgery from extraoral approach and from a skin incision to remove this. If you see the proximity to the nerve in the panoramic view, you need to order a CBCT to more evaluation. The class C of Pell and Gregory classification and class 3 are more difficult than the other classes. This slide is this schematic is not true. This triangular is more difficult. Proximity to the second molar make your surgery more difficult. Also, dense bone. Look at this dense bone here. It make your surgery more difficult. Narrow PDL space make surgery more difficult, and divergent and curved roots and also long and narrow root make surgery more difficult. Let me erase this mark.
I mean, we have an interruption. Would you?
Yes, of course. I will repeat it. I was just erasing the marks.
From dance okay.
Yes. This is the look at this dense bone here. It make your operation more difficult. Narrow PDL space, divergent curved roots, and long and narrow roots. These are the other factors that make the operation more difficult. You should pay attention to these factors. It means that when you look at the panoramic view of your patient before your surgery, you should take care about all factors to find out one of these factors make your operation difficult. Imagine you have a patient with, for example, 4 or 5 of these factors. So this is a really difficult case. You should evaluate yourself. If you are at the first of your surgery, if you are at the first level of surgery, you should start with more easier cases, because the learning curve, you should pay attention to the learning curve. After a while, you can go to the more difficult cases.
Mm-hmm.
Yes.
You know, Hamid, I really appreciate your slides. It's just very interesting and well classified, and I'm really enjoying your presentation. That was wonderful. I'm really appreciate your
Hope
presentation.
it would be helpful for my all colleagues. Let's have a little talk about the upper third molar. Regarding to the classification of maxillary impacted wisdom teeth is based on the long axis angle with the adjacent tooth, as well as on the distance from the occlusal table. I show you in this slide. Look at this. Let me have a marker. Look at this, the angulation. Oh, okay. The angulation between adjacent tooth and the wisdom teeth, and also the distance between the occlusal surface of the wisdom teeth and the occlusal plane. These are helpful in classification. But keep in mind that unlike lower wisdom teeth with a distangular and vertical position in the maxilla have easier surgery. So when you encounter this kind of impaction in maxilla, it is easier than this type, because a little bit this is a mesioangular or maybe this is a vertical situation. So distangular in maxilla is more easier than the other types, because this is obvious, because this is when you want to remove this tooth, the path of removing is to the empty space, so it is easier to remove the third molar with distangular angulation. I want to go past these slides to go to more clinical slides. In this slide, I like to talk about some common complication of maxillary wisdom teeth removal. One of the most common complication is fracture of tuberosity, but this condition is more common when the third molar has completely erupted. So in erupted maxillary third molar, the fracture of tuberosity is more common than in impacted third molar surgery. Also, because of close contact of sinus to the maxillary third molar, it is a common complication to have a oroantral fistula because of, especially when there is a large sinus around the maxillary third molar. Look at this slide. This was a patient referred to my clinic with an huge oroantral fistula due to removing a wisdom tooth. I tried to close this by a double layer closure by a buccal fat pad as a first layer and buccal advancement flap as a second layer. Look at here, I make an quadriangular flap here. Look at these. This is oroantral. Let me make a pointer. Look at here. This is the oroantral fistula, and here it was after removing, after elevating the flap, I found that the previous dentist tried to remove the tooth from the sinus from this hole, and the situation is really bad. I used the buccal fat pad for the first layer of closure, you can see here, and buccal advancement flap for completely close the oroantral fistula. Okay, let's talk about surgical techniques. The first and the most important step is in the surgical process is proper anesthesia. As this is a surgery, so the patient have anxiety, so pain control and proper anesthesia is really important for starting your surgery and have a good surgery. Conservative and gentle elevation of the soft tissue flap for exposure and provide access to the surgical field is one of the most important stage for us. If you have a good flap elevation retraction, you can have a good access, good visual aspect to the field, and clean field, bloodless field. It would help you to have a good surgery. After reflecting the flap and elevating the flap, you should assess the area in terms of need to remove the bone for tooth exposure and also to whether you need to section the tooth, splitting the tooth or not. And after that, you remove the tooth segment and irrigate the place rinsing the surgical area with saline, and also smoothing the bone speckles by bare or by bone file. I always suggest the clinicians to irrigate and rinse the surgical field very much. If you previously, before this lecture, rinsed your surgical area by a syringe of 5 cc, please do this 3 times from after this lecture. If you rinse the field very good to remove particles, bone particles from the area, the swelling, the pain, and any post-operative sequela, it will be better for your patient. It's really important. And after that, suture the place. To access the area and uncovering bone that need to be removed, the surgeon must evaluate a suitable mucoperiosteal flap. It means that the flap in which we need for doing a wisdom teeth surgery is a mucoperiosteal flap. It is a full thickness flap because we want to do surgery on a bone, so we need a full thickness flap. The extension of the flap always is to, I think my connection become unstable again. Do you have my video? Do you have me?
Yes, yes, yeah. You have good streaming, yeah.
Okay. The extension of the flap should be 2 teeth anterior to the wisdom teeth. And the most common flap is an envelope flap, especially in the lower jaw. I always use...
Option. Would you please repeat it, that slide? Yeah, the above slide.
Okay, the extension of the flap is 2 teeth anterior to the wisdom teeth. And the most common type of flap we use for wisdom teeth surgery is envelope flap. It is enough because, especially in mandibular surgery, I can tell you that I never use any releasing incision for mandibular wisdom teeth removal, because this distal extension that we go through the external obliques, I will show you in next slides, it is like and releasing and give you a good access to the area for removing the third molar in mandible. But in maxilla, I will decide based on the amount of impaction. I mean that when the tooth is under the CEG of the second molar, I use a triangular flap like this slide. But when there is between above the CEG of the second molar, I just use an envelope flap to remove it. Okay, after removing the, after reflecting the flap, we should make a decision for removing bone from the occlusal surface and buccal surface of the tooth, and also evaluate if whether we need to section the tooth or not. This slide shows us how to section a wisdom tooth according to the angle with the adjacent tooth. I will start from the left side. If you have a mesioangular, you can just section the distal part of the crown and after that remove the tooth. In a vertical wisdom teeth, you can section the tooth into the 2 parts, mesial and distal, and then remove each part separately. And in a horizontal position, you can section the crown completely, remove the crown first, and after that, remove each root separately. It is, about to removing maxillary third molar using elevators. After reflecting the flap, you can use the elevator, but Please be careful. Do not use excessive forces, because excessive forces may result in unwanted fracture of the tooth, bone, and adjacent teeth. So in maxilla, it is easy, but you should be patient and wait to remove the tooth very slowly. After removing the tooth, we should use bone file or burrs to remove speckles and also clean the wound completely with large amount of sterile saline. It is very important to remove the follicle, the soft tissue and the follicle of the impacted tooth, because if you left them in the place, it maybe in the future they could become change and become a pathologic problem, make a pathologic problem for the patient. Okay, in this slide we can see step by step. Let me change my marker to a pen. At first, we remove the occlusal and buccal part of the bone. We ditch the wisdom teeth and then make a purchase point or fulcrum point. Both of them term is true. Purchase point or fulcrum point, and then remove the tooth. And then remove the tooth. Or after removing the bone like this and ditching the tooth, we can section it by a burr and remove each part separately. Let me erase these marks because I want to go to the next slide. Or in a distangular tooth, we remove the we section the crown. Oh, where is my pen? Where is my pen? This is my pen. We section the crown completely, remove the crown, and after that remove the roots. Or in a horizontal tooth, we section the crown, and after removing the crown, we can remove the roots separately. So it is important to understand that which part of the tooth is inhibit you to remove it from the socket. So it is your option to section the tooth, for example, from the crown or between two roots. It depends on the angulation of the tooth. For extraction of the upper maxillary vertical impacted wisdom tooth, look at this, because this was below the CEG of the second molar. It is a triangular flap. Removing the bone from buccal and occlusal, use an elevator and remove the tooth. This slide is showing you a step by step a mesioangular impacted mandibular wisdom tooth removal. This is my pointer. At first, use a circular incision. Look at here, I changed the passive incision through the external oblique ridge because the lingual nerve is from the crest of alveolar at the lingual part of crest of alveolar. Never extend your incision on the crest of alveolar. You should change the direction of incision from here circular from the distobuccal line angle of the second molar to the external oblique ridge. It will help you to prevent from lingual nerve damage. This is the extension that I told you in the previous slides, that this extension to the external oblique ridge will help you to have a good access to the area. Reflecting the flap, look at this bloodless area. Because if you reflect a mucoperiostal full thickness flap carefully and tightly under the perios, there is no blood in your area. So it helps you to have a good surgery. Look at this slide, number 3. This is my periostal elevator. If you need more access, you can use this technique. Put the periostal elevator under the lingual flap very carefully, and this is the Minnesota retractor. You can keep these two retractors simultaneously by one hand technique. This is my technique. Look at this. With this technique, you have very good access to the area. After that, start ditching the buccal aspect by a round pair and make a purchase point here and removing the tooth like this and suture it. Look at this slide. There isn't any blood during your surgery. It is important because if you pay attention at the first step, when you are reflecting the flap, you have a better field of view during your surgery. Let's have a look at another case. This is a case of horizontal, but I think here I mentioned wrong. Here I mentioned mesioangular. It is not mesioangular, it is a horizontal tooth. This is a CBCT view.
And you know, Hamid, I'm sorry to interrupt you. You know, me as an periodontist, really like to do this flap and do this incision, as you mentioned that we don't like to do, and especially in the lower jaw, to do an vertical incision and releasing incision, because that the first of all, it's maybe the another sequel or another outcome of this one is to be maybe a recession, and the second one is the post-operative pain. You know, the post-operative pain of the vertical incision is much more if you are compare it with the sulcular incision.
Yes,
right now, I think that I'm gonna find another topic for another session. That's with the modification and some type of flaps on your surgery. I think it's very interesting for the audiences. I think so. Yeah.
No, why not? That would
Okay.
be a good topic for next.
Yeah.
Okay, let's look at this another wisdom teeth surgery done by me. The first, I again do the flap incision, reflect it. Again, I use periostal periostal elevator and Minnesota to have a good access to the field. Ditch from buccal side to some in distal side. When I do this, because I protect the lingual nerve by this periostal elevator, I do this with a very better mind. And after
sorry, you have an X-ray of them, a panoramic of them, and also.
Yes, I showed in the previous slide. I will show this again. Let me erase this. This is the.
Okay. Yeah, this is a mesioangular. Okay. Yeah, that's a very pretty fine. Thank you.
Welcome. And after that, section the crown completely and remove it, the roots separately. Okay, wisdom tooth extraction is a surgical procedure, and as I mentioned previously, is of great anxiety to the patient. So it is necessary to use pharmacological and non-pharmacological methods for reducing anxiety. Non-pharmacological methods such as your patient management is the most important part. If you have a good relationship with your patient, with a very silent area, non-stressful area, operating room, it is very helpful for patient to reduce the anxiety, so you can have a better field of view and a better feel for your surgery. Also use long-lasting anesthesia, especially for the mandible. Use painkillers prior to surgery and before the anesthetic wear off. It is you can prescribe the painkillers for at least 3 or 4 days for your patient.
Hamid, would you please come back to the anxiety? Yeah, because at that time we had an interruption.
Yeah. Sorry for interruption. I was talking about anxiety. As you know, wisdom tooth extraction is a surgical procedure, and I mentioned in the previous slides. So it has a great anxiety for the patient. We should try to control the patient anxiety, both with pharmacological and non-pharmacological methods. Non-pharmacological methods like our patient management, the silent operating room, good environment for your patient, and also always we need a long-lasting anesthetics, especially for the mandible. Please prescribe painkillers before starting your surgery because it helps your patient to have less pain after the surgery. And the dosage of these painkillers could be prescribed for at least 3 or 4 days after the surgery. Also, we always suggest patients to use ice packs. It helps them to have lower swelling. It helps them to experience lower pain. I always tell to my students, if you do surgery without removing bone and on a healthy person, you do not need to prescribe antibiotics. But if you remove the bone, it's better to prescribe antibiotics for at least 1 week. Trismus, mild to moderate trismus following mandibular wisdom tooth extraction is normal. But if you encountered severe trismus, you should looking forward some problem in the field of your surgery. The recovery period is around 7 days. After 7 days, if your patient have pain, edema, or trismus, you should reevaluate the field. Maybe something happened there. This is another article that I published with my colleagues. It is about a randomized double-blind controlled trial comparing ibuprofen versus a combination of ibuprofen, acetaminophen, and caffeine. We concluded that there was no significant difference between prescribing ibuprofen or prescribing a combination of some of these 3 painkillers. So it depends on you which one is better in your practice. This is another article I published with my colleagues. This is about effect of aloe vera mouthwash on post-operative complications after impacted third molar surgery. And again, it was a randomized double-blind clinical trial. We concluded that there is aloe vera mouthwash is effective in the management of post-operative complications, especially for pain and swelling. As you know, the trend of surgery in all over the world nowadays is doing minimally invasive surgeries. So piezoelectric surgery could be helpful in.
We have interruption. Would you please starting from this slide from piezo surgery? Yeah.
Yeah. Recently and nowadays in all over the world, there is a trend to do minimally invasive surgery. And so piezoelectric surgery is a good option doing a minimally invasive surgery for patient for removing their wisdom teeth. Also laser, erbium YAG laser could be helpful in removing a wisdom teeth. This is a video, but because this is not mine, I just pass it. We published another article, and we try to compare between piezoelectric surgery and erbium YAG laser surgery for removing wisdom teeth. We concluded that in the pain immediately after surgery, in the term of swelling immediately after surgery, in the amount of mouth opening immediately after surgery, 2 days and 7 days after surgery, and also in the time of the surgery, in these four terms, in all of them, piezoelectric surgery had better results. So piezoelectric surgery is a good option for doing minimally invasive surgery for patients. This article is mine. Me and my colleagues published it in the Maxillofacial Plastic and Reconstructive Surgery, I think in 2000, let me find it. I think 2019, it was 2019. Look at this. Let's talk about coronectomy. Coronectomy is a treatment option for involving removing the crown of the wisdom tooth whilst keeping the root in place. When you have a patient with an impacted tooth with a close contact with the inferior alveolar nerve canal, one of the options is coronectomy. Look at this CBCD. Here you can find the close contact. Here you can see that the root is completely in the inferior alveolar nerve canal. I decided to do coronectomy for this case after reflecting the flap by use of piezo surgery. After reflecting the flap, after reflecting the flap, I ditched the wisdom teeth by using of the piezo surgery, and then by using a saw, piezoelectric saw, I sectioned the crown completely, removed the crown, and this is the crown of the tooth. Again, interruption.
Interruption. Would you please start it from the ditching? Yeah, from the ditching.
Okay, here I ditch with piezo surgery, and then section the crown with a piezo saw, and remove the crown, totally remove the crown. Here you can find the crown, and here this is just the root remaining in the bone, and I sutured the place. This is a coronectomy by use of a piezoelectric surgery. It is a simple surgery and could be helpful in cases that third molar is near the inferior alveolar nerve canal. This is
I have a question in this coronectomy, because this is a very amazing technique. What time do you refer or to do the root canal, these remaining roots? Okay, for instance, if you have a very inflammatory processing in the pulp of the this wisdom tooth, is there you remain it intact, or to be referred or to be done the root canal therapy, is filling the root canals, or and after that you're going to be stitching and to suturing the flaps?
When you want to decide to do a coronectomy for the case, you should keep in your mind that if the roots should be healthy. If there is a problem in the root, you cannot do this kind of surgery, because the risk of infection is really, really high after that. Okay, and
So,
after do the coronectomy, you should have a close contact with your patient, and the patient should be evaluated during the first 2 weeks. In case of any problem encountered, you should do again another second surgery and remove the roots. So always you should tell your patient that maybe you need to do another surgery after 2 weeks if you encountered any problem. But in my practice, I think almost more than 100 coronectomy, but I remember that just 2 cases came back to my office, and I removed the roots in a second surgery. I think doing coronectomy by use of piezoelectric surgery, because of the nature of piezosurgery, which reduce the amount of bacteria because of the irrigation, ultrasonic irrigation, and because of the very, very low temperature produced in the
yeah.
place.
Just starting from the mechanism of the piezosurgery to
As you know, because of the nature of piezosurgery mechanism that irrigate the place, do not do not raise the temperature, bone temperature in the place, and remove the bacteria from the place. Because of these mechanism of piezosurgery, doing coronectomy by means of piezosurgery will be really helpful to less the complications, and it will be lower the needs of second surgery to remove the roots.
Mm-hmm.
This is another cases. I do coronectomy for him. If you look at this case, again, there is a close contact to in the slide, in the cut number 15, close contact with the alveolar nerve. And so we decided to do coronectomy for these cases, reflecting.
Hamid, would you please use a very thicker laser pointer?
Yes. Let me change the thickness if I
or to be done with the pen, you just
okay,
want
I
to.
will do with the pen.
Okay, I think the pen
Okay.
is more.
Here I reflect the flap. Oh, sorry. There is my pen here. Here I do the flap, reflect the flap, full thickness. Again, you can see that there is, it is a bloodless area. I ditch the place with a piezoelectric in the buccal surface. Here, more deeper ditch. And now section the crown with a surgical, with the piezoelectric saw. Here you can find the section part from the crown. And because I decided to, because we should know that for coronectomy, you should remove the crown without any force to the roots, because each small movement in the roots will encounter problem after surgery. The roots, should be, no movement, should be stable at the place. You just do surgery and do forces on the crown. So here I decided to section the crown by the piezoelectric saw and remove the crown in 2 parts.
Yeah, that's great. Great.
You can see here I remove different parts of the crown in 2 parts. And finished, it just finished. Okay, sometimes we encountered really deep impactions. as I mentioned, deep impaction and really deep impaction, impacted teeth do not need elective surgery, but sometimes the patient have problem with his impacted teeth, so we need to remove them. If there is really deep impacted, there are some options for removing them, such as corticotomy, like this slide. And it means that let me find my pen again. Sorry, I missed the slide.
Okay, no problem. Wow.
This is corticotomy. If you have a patient with a really deep impacted tooth, with a problematic impacted tooth, this is one of the techniques. We can remove it, or sometimes you encounter multiple teeth impaction. Again, we can do corticotomy to remove it. Orthodontic extraction is another option this technique is commonly used for wisdom teeth to remove it from dangerous proximity to the inferior alveolar nerve prior to extraction. Sometimes we maybe do sagittal split osteotomy to remove the wisdom teeth. A problematic wisdom teeth, not a asymptomatic wisdom teeth. Or we do down fracture left osteotomy for removing the upper temporal.
Hamid, we had an interruption. Would you please, in this blue slide, starting from blue slide, yeah.
Okay. Yes, sometimes if you have a symptomatic or problematic wisdom teeth, deeply impacted wisdom teeth, we can do sagittal split osteotomy, like this slide, to remove it, or down fracture left osteotomy for removing upper third molar, problematic third molar. Or if you have a very, very impacted third molar in mandible, we need to remove it by an extraoral approach with incision from the skin and remove it. Thank you so much for your attention. I hope it would helpful for you. I'm with you.
Hamid, I had an interruption from at the end of the extraoral incision.
Yes. Oh, look at this. This is a really deep mandibular third molar. You can see this here. And so for removing this, we needed to do an extraolar incision on the skin. And from extraolar, it is really easy to remove it, but we should keep it for really deep impacted tooth. It is not a common approach for removing mandibular third molar. Thank you so much. I want to appreciate my mentor, dear Ardeshir, who invited me to this dental talk, and I hope it would helpful for you, my lecture, and I hope I can be with you in next episodes of Dental Talk again and be with you.
Hamid, I really appreciate and really thank you for a very informative presentation. I really enjoyed it, and I'm pretty sure that most of the audiences will be at the end of this session that will find it very useful for them, and to be categorized in this, the different model type of this impaction. It's going to be classified in their mind. It's to be going to be good decision making for them. And I'm from this here, I'm asking you and to become to the another session. I think first of all the flap design, that this is a very interesting for them, because that you share your knowledge for the infrastructure and for the basic uh, type of the extraction of impacted tooth. But I know, I'm pretty sure as an periodontist that's know that they really needs to understanding and realize that what kind of incision, and then after that I think that you show that's very good for the tooth removal, for the sectioning, for the bone removal. And but but suturing, and it's a very important, the suture in different parts of your flaps. And uh, actually I'm there was a general speaking that there was a wonderful session we have with you, and according this is then a recorded dental talk. I wanted to ask in the audiences that's if there are any question, please send it to Ever Smiles group, and I'm asking to Hamid that's about the another session.
Sounds
He will, as soon as possible, they will find and they will answer in all of your questions. And that was a wonderful talking with you, Hamid.
thank you very
Good
much.
luck and see you soon, the another session. Okay. Thank you very much.
Thank you so much. Bye.
Thanks. Bye.
Hey, bye.
Thanks. Uh, okay. Hamid, I think I stopped recording. Are the recording is still?